Hi, good evening, and welcome to this evening's webinar, 13th in our current series of KOL webinars. This evening, we're talking about diabetic foot management and MDT approach. Tonight, delighted to be joined by, live from Glasgow, Gail Morrison. Do you want to say hi, Gail?
Hi there, everybody.
Thanks for joining us this evening, Gail. Really appreciate it. Gail Morrison is a diabetic team lead for orthotics at NHS Greater Glasgow Clyde. This evening, Gail will be presenting on the condition and causes of diabetes and diabetic foot ulcers, the issues and concerns around treating the diabetic foot. Gail will finish our presentation discussing the challenges of setting up an MDT service and how they got to the gold standard service, which is now utilised within the NHS Greater Glasgow and Clyde. So just to give you a little bit of an outlook or an agenda for this evening. So Gail will take you through the presentation. We'll have a Q&A throughout the evening. And then we'll do a quick presentation on the rebound diabetic walker at the end. Now we do that by having slightly different camera angles. We have the front view camera here on the main big screen. We then have a table cam, which allows us to go through the product in a little bit more detail. And I'll be doing that after Gail's presentation. And we also have a fitting cam as well, where I'll be fitting the diabetic walker to my leg and give you a bit of a view in terms of us walking about. Now, this is the first time you've joined an Össur webinar. There's a couple of housekeeping rules that we like to discuss at the start. So how to communicate with us. If you've not joined the Zoom platform before, and I'm sure many of you have, there's a Q&A function at the bottom. So do put your questions to Gail at the bottom there, and I'll be managing that through the evening, and we can ask Gail your questions. There's also a chat function, which my colleague Ajmia is manning. So if you do have any questions regarding you can't hear, you can't see, or anything else related to that, please do ask and Aj will reply. The session is being recorded. It's then posted onto the Össur Academy YouTube channel, usually within 48 hours. You will also receive an e-certificate for your attendance this evening, and we'll also send up some follow-up questionnaires as well. So please, if you do have time, fill them in, and we can discuss topics that you may like in the future, but also how we can improve the webinar format. So to get things going, I'd like to introduce Gail. Gail has been the diabetic team lead for orthotics in NHS Greater Glasgow and Clyde for 3 years, having worked with the NHS in Glasgow since 2005. The Orthotic Service in NHS Greater Glasgow and Clyde is one of the largest services in the NHS in the UK, covering 8 hospitals and employing 20 orthotists. Having graduated from the National Centre of Prosthetics and Orthotics in 1997, Gail worked as a prosthetist in Manchester for a year before switching to her true passion, orthotics, in 1999. She has worked in various centres across the UK, including Leeds and Middlesbrough, before taking up the post in Glasgow in 2005. It was here in Glasgow, employed directly by the NHS, that she became part of a true multidisciplinary diabetic foot team, which meets once a fortnight and includes diabetic consultants, podiatrists, orthotists, diabetic specialist nurses, and dietitians. As the diabetic foot service has developed over the last 15 years, Gail has worked in all areas of the service within Greater Glasgow and Clyde, developing relationships with all the consultants and podiatrists across the board. The clinics now have regular input from vascular and orthopaedic services. Gail has been the chair of the diabetic foot subgroup of the Diabetic Management Clinical Network in Glasgow since 2018 and attends the National Scottish Diabetic Foot Action Group, whose ethos is to provide a cohesive national diabetic foot network dedicated to service improvement and better patient outcomes throughout Scotland. So quite honoured to have Gail speaking for us this evening. So with that, I'll pass you over to Gail. Please do put your questions in the Q&A function, and then I hope you enjoy the evening. Thank you. Over to you, Gail.
Thank you. Now, have I done that? Am I sharing my screen? Oh. Is that us? Looks like it. Yeah, great. So thank you for joining us this evening. As Stuart has said, my name's Gail Morrison. I'm the diabetes team lead for the Orthotic Service in Greater Glasgow and Clyde. So this is the largest in-house NHS orthotic provider in the UK. 20 orthotists is quite a large team, and I have to say I do work with the best team of orthotists in the country. We have a huge mix of experience within our team, which brings a strength to it I didn't think would be possible if I didn't work in it. I want to thank Össur for inviting me to speak this evening. It's always an honour to be able to kind of show off, or so to speak, the service that you work in, and I hope I do it justice this evening, as I'm very proud to work in it. So if I can hand us back to Stuart, and we'll go to a little poll just to see what the professions are in the audience tonight. That'd be really interesting. Thanks.
Thank you, Gail. So we do a little a polling session. So if we could just have an idea so you can get used to it. If you can put in, what is your role? So we've got doctor consultant, physiotherapist, orthotist, podiatrist, occupational therapist, orthopedic practitioner, student, and other. So I can see that 50% have voted already. So we can keep that going. And I think we're up to 80% there, so I'll end the polling and share that with you. So this is a first scale for your webinar. Orthotists are in the lead for the first time. It was usually physiotherapists. So we've got 1% doctor consultant, 19% physiotherapist, 55% of the audience this evening are orthotists, 11% podiatrists, 4% orthopedic practitioners, 5% student, and 4% others.
That's great, thanks very much. Okay, well, we'll carry on with the rest of the presentation. I will warn you that there are a few pictures of some foot ulcerations, so if anyone's eating their dinner while tuning into this, you have been warned. So, my brief tonight was to talk about diabetes, foot ulceration, other complications related to diabetes, and the MDT treatment and the setup within NHS GGC. But it's a huge, massive subject to cover. So my first thoughts was, where do I start with this? Because it is such a massive subject, it causes so many different things to malfunction within the body. The condition's complicated, it's complex and multifactorial. The patients we see in the foot clinic often have very many other medical problems caused by the diabetes, and although we might not be treating those conditions, we as orthotists or other professional, we need to be aware of them, and more importantly, we need to be aware of the implications of people in people's lives as a whole. So this evening I intend to talk briefly about diabetes itself. Everybody knows more about diabetes, so I'll just cover that just briefly. Some foot ulceration, some of the other foot complications, but mostly I'll go over the pathways in which the patients are directed to the MDT in Glasgow, and who's involved in those. So what is diabetes? First of all, I wanted to have go to another poll, just to see how many types, if you can tell me how many types of diabetes you think there are.
How many types of diabetes are there? Is there 2, 3, 5, or 6? I think someone's tried to put the answer there in the chat function. So we've got 60% have voted. We usually leave it to about 80%. So we're just about there now. So I'll end the polling and share the results. So 34% of the audience believe there's 2, 36% of the audience believe there's 3, 22% believe there's 5, and 8 believe there is 6. So quite a good spread over there.
Yeah, it's a good spread. Well, most of you will probably be surprised to note that there are 6 types of diabetes. We have type 1 diabetes, type 2 diabetes, which is probably the ones that you are very most familiar with. We have gestational diabetes. Happens when women are pregnant, and during that pregnancy they become diabetic. We have something known as LADA, latent autoimmune diabetes of adulthood, sometimes known in it's as a type 1.5 or 1.5. We have MODY, maturity onset of diabetes in the young, and we have neonatal diabetes mellitus, NDM, and this is diagnosed between birth and 6 months old, which is extremely rare. So in the foot clinics, then obviously it's type 1 and type 2 diabetes that we're mainly dealing with. These are the ones that cause the kind of chronic long-term disorders and problems within people in the population. Type 1 being an autoimmune disease causing insufficient or no production of insulin, and type 2, a chronic disease where the body becomes resistant to the effects of the insulin production. So when we talk about diabetes, we think of sugar, we think of glucose, to be exact, and we need that as energy within the body to function. So that is taken in our food and as carbohydrate, and carbohydrate plus the oxygen will react in the body and give us carbon dioxide, water and energy. And this energy is what keeps us going. We need the fuel. So sugar's not a bad thing. But what's supposed to happen in the body is that insulin's produced when we take in sugar, and the insulin's a hypoglycemic hormone. And if the glucose levels rise above 5 millimoles per litre, the insulin will be released by the pancreas, and the insulin will continue to be released until those glucose levels drop again. If the sugar levels go too low, then glucagon is then produced, which is a hyperglycemic hormone, and this will continue to be produced until the glucose levels rise above to 5 millimoles per litre. So this is what's supposed to happen in the body, and this is how the body balances out the amount of sugar in the body, so that all the organs can work at their optimum point. So obviously diabetes means this is not working correctly. In type 1 diabetes, insulin is never produced, so the glucose levels just continue to rise and stay high. In type 2, the body becomes resistant to the effects of the insulin, causing the same effect. And this is what the diabetes is. So what does that mean? It's all very well saying that, but what does that actually mean? So we have this increase in sugar levels in the body, but what it does is it builds up in the bloodstream, and it affects the microvascular system, the very tiny little blood vessels in our body, which go to the eyes, the kidneys, the feet, the brain and the heart, and it also affects the nervous system, and this is when we get peripheral neuropathy. So we're obviously talking about feet. We want to talk about in the foot clinic, it's the foot that we're dealing with. So we have some patients who are presented with us with perhaps neuropathy, so they've got a sensory impairment, they've got some muscle atrophy, and the people that we see tend to have had diabetes for a fair amount of time. And then these people, then because of these aspects that happen, we then get the foot deformities. And these are the kind of typical foot deformities that we might see. You've got on the left the pes cavus foot, where we end up with a very high arch and very prominent metatarsal heads. And then on the right, we have the kind of clawing of the toe effect. So we have the kind of raised dorsal aspect of the toes at the proximal interphalangeal joints. And these then can rub on shoes. And then those deformities can then form these kind of ulceration patterns. And these are the kind of typical ulcerations that we see commonly in the foot clinics. Now, we've got one on the left in the metatarsal heads, and we've also got on the dorsum on the toe is probably rubbed on a pair of shoes. Now, along with the sensory impairment, this obviously means that the patient doesn't really feel this when they walk on it. So they just continue to walk on it, which makes the ulcer worse, doesn't allow the healing process to happen. They're not getting that early warning sign that tells them that something's not working right, or it's not right and it's sore. So they could be walking around on a callus. They could even walk around on a piece of Lego and not feel it. But with the additional aspect of the blood sugar levels in the body, this makes it harder for these wounds to heal. And they're more likely to have the vascular impairment, which means the blood's not getting to those wounds to help heal the wounds. So they take a lot longer to heal. Now, another one of the complications of diabetes that comes along with sensory impairment and peripheral neuropathy is the Charcot foot. So here's a couple of pictures demonstrating the Charcot foot, where we get this kind of rocker bottom effect, where the midfoot has collapsed, and that midfoot area has now become the most prominent area of the body. And that takes all the load through the body down to the ground. Now, that area was never designed to take weight, so you can imagine the skin on there is fairly fragile, and it is prone to break down. Now, Charcot, when you work in a foot clinic, you do see it fairly often, and sometimes I forget myself that it's actually quite a rare condition, and it occurs in only up to 10% of patients with diabetic neuropathy. So they might have neuropathy, but they might never ever develop this Charcot foot. But we do seem anecdotally, I feel as if we do seem to see a lot more of them now than we did. Now, I don't know whether that's because they're just getting better at being spotted out there. Who knows? So we've got a patient. They have deformity, they have a wound, they have high glucose levels, they have vascular impairment, and they have probably a poor diet. So the person presents to another healthcare professional, and they might be able to deal with one aspect of this, but there is no healthcare professional that can deal with all of these aspects. And that is why they need to see multiple professionals and to deal with it, but they also need to see them in an order that's unique to them. You can't, there's no linear way. You can't sort out the deformity and then deal with the wound and then deal with the glucose level. It all has to be kind of dealt with, intermingled, and each person is unique and their treatment plan is unique. So this is when we need the multidisciplinary team. So I've shown here the patient's in the middle and they've got all these professionals around it. There's not many clinics that will have all of these things attached to it. A lot of the clinics that I've worked in the past, then when the patient will come in and there's usually a podiatrist, a diabetes consultant, and perhaps an orthotist. Now, the consultant might be there fortnightly, monthly, the orthotist might be there fortnightly, monthly. And then some of the other aspects, some clinics might have one, others might have another, or some kind of link to another. But really, to have a true multidisciplinary foot team, all of these things really need to be there for the patient to give them the best treatment. So I just want to go to another little poll, if I can pass back to Stuart, just to kind of get an idea if people do have access, if they have got a local multidisciplinary foot clinic that they know of.
Thank you. So I've just popped that up on the screen. So in your practice, do you have access to a local multidisciplinary foot clinic? So quite a simple yes or no answer. So we can see the people answering rocketing up. We're up to 70% already. We're nearly at 80%. So I shall stop the polling there and share the results. And it's pretty much 50-50 as you'd expect. So we've got 55% saying yes and 45% saying no.
Wow. Okay. So that's very interesting, because obviously that, to me, is quite a normal thing to have a multidisciplinary foot clinic, but it might not be so normal. Stuart, the poll results still up on the screen. Are you able to take that down? Oh, brilliant, thank you. So I thought I would give you a little bit of a geography lesson. I don't know where everybody out there who's listening to that is fully familiar with Scotland and indeed where Glasgow is. So this is a picture of all the health boards in Glasgow, in Scotland, sorry. And that includes the islands. They are classed as health boards in their own right. So you can see Greater Glasgow and Clyde is number 7, just down there in the middle, below 5 and below the massive number 8, which is NHS Highland. So as you can see, our geographical area is very, very small. However, our population is massive in relation to that geographical area. This shows that the population density is almost double that of the next health board, and we see that the patient number that we see in Greater Glasgow and Clyde is the same as all the other boards put together. So it is a massive board. We deal with a massive amount of patients, and to do that, we have 8 foot clinics spread about that board. We have 2 in the north, 1 in the west, 2 in the south of Glasgow, and we have 3 down the Clyde coast. It takes you right down to the coast area. We've got the one at the bottom there, the Vale of Leven, is a monthly clinic. It's a little small cottage hospital. In the south, we've got the Queen Elizabeth University Hospital, which is a massive hospital. And the New Victoria, we have Gartnavel in the west, and in the north, Stobhill has 2 clinics. Now in Glasgow, out of the 20 orthotists that work within Glasgow, we have 7 orthotists that work within the diabetes, covering all of those clinics, which is brilliant because it means that the group of orthotists there are all able to kind of cover for one another, especially if we've got annual leave, and we can step in for courses, etc. And we all work very, very closely together. We've got a large range of experience within that team. And we've got some orthotists that are maybe only 2 or 3 years graduated, to myself, who's got 20 years experience. But we all work very closely together. We have an induction service at the beginning to anybody who's new into the diabetes service, and we go over a bit of education and what's expected within these clinics. We strive very, very hard to give equity of care across the board to all of the patients. We work very closely with our podiatry colleagues within the clinics, who, let's face it, they see the patients much more often than we do. We have also provided training to our podiatry colleagues to fit first-line pressure redistribution within the community clinics, and also the training included when it was appropriate for them to refer on to orthotics. The podiatrists fit the pressure redistribution, such as a rigid rocker-soled shoe to accommodate dressings. They'll do that at the first contact with the patient, and then the patient is booked into a multidisciplinary foot clinic. And then the orthotist will then review this and assess whether to carry on with it or whether something to redistribute pressure further is necessary. Perhaps with a walker boot, with a custom insole. So with COVID, we've had the opportunity to look at our diabetes services. Because the diabetes services were kind of suspended, they were reduced to essential work only. Podiatrists are continuing to see patients with new wounds or deteriorating wounds, and they're referring to orthotics just when necessary, and have had medical input in a reduced capacity. The foot clinics are just about to start resuming. We are looking at how we're going to do that, and we're doing it in a kind of phased way. But we're also going to be amalgamating 3 of those clinics, and these are the services here that you can see. We've got Queen Elizabeth University Hospital and the New Victoria in the south, and Gartnavel in the west. That sector of Glasgow is going to be coming together to form the South and West Diabetic Foot Service, which means we, in one hospital, which is this one, the Queen Elizabeth University Hospital, we're going to have a twice weekly foot clinic services with 4 consultants at those clinics, a team of podiatrists and 2 orthotists at each of the clinics as well. So this, we think, was going to be the biggest diabetic foot clinic in the country. It will give greater access for our patients to get to see the foot team. They should be able to get access within 3 days if absolutely necessary, if urgent. So we're very excited to be part of that and be part of this new team that's starting. The hospital is on one of the largest hospital sites in Britain, if not in Europe. It's a huge hospital site. And it has regional services for spinal and prosthetics, which cover the whole of the west of Scotland. So we have this massive hospital, but how does the patient get to the right place? Because they're coming from all over. So we need to have very clear pathways to get the patient to the right place. There's no point in a patient pitching up at A&E, the hot swollen foot, or their foot's been next to a fire and they burnt it, or they've developed a pressure wound whilst on the ward, or they're admitted to a ward from home with a wound on their foot. The patient could attend a physio appointment and mentions that they've got a cut or a blister, or they attend a general orthotic clinic for maybe perhaps fitting a footwear or something, and the orthotist sees that they've got an ulcer on their toe. Or they attend their GP for a completely different issue and so happens to mention that they've got this sore on their foot that's not healing. So how do we deal with those? So they're split into two sets of pathways. We've got inpatient pathways and we've got outpatient pathways. The inpatient pathways are driven, a few years ago there was a campaign devised from the Scottish National Campaign, initiated by the Scottish National Foot Action Group, and it's called CPR for Feet, Check, Protect, Refer. And this campaign was in response to an audit done in 2013 of inpatients across Scotland, and it's since been repeated in 2019. But back in 2013, it was found that 2.4% of inpatients with diabetes developed a new foot lesion whilst in hospital. 57% of these patients had not had their feet checked. 60% who were discovered to be at risk of developing a foot ulcer did not have any pressure relief in place. So if someone is admitted to a hospital now, as part of the nursing admission papers, the patient's feet are checked for the risk of developing an ulcer and checked if they have an ulcer. They're given appropriate protection, and if need be, they're referred to the podiatrist if an ulcer is present. If the ulcer is graded as a grade 2 or above, they will also be referred to orthotics. And this is the grading tool that we use for static pressures. So that's inpatients. When we come to outpatient pathways, as you can see, they can come in from lots of different ways. The GP, A&E, community podiatry, orthotist, acute receiving unit, private podiatry, or even the patient themselves, especially if it's somebody who's previously had an ulcer and they've maybe noticed that it's either come back or they've got a problem somewhere else, then they need to be able to initiate treatment themselves. So in Glasgow, sorry, I'll go back, the podiatry service itself, they redesigned their service a few years ago to respond to referrals for patients who are in a high risk category, as there was an inequity of care across the board in that patients with diabetes were getting seen sooner than patients without diabetes who perhaps had vascular disease or a rheumatological disorder. So I'm just going to stick to talking about diabetes, as that's what we're here for tonight. So these patients are now seen by the podiatrist within 48 hours, and all these areas will refer into them, and then they would be booked by them for a multidisciplinary foot clinic at the most appropriate time to see them with the full team. They've had the training that I mentioned before to fit first line pressure distribution, so that they can deal with the patient and give them something that they need, some kind of pressure redistribution at that first contact. And then when they come to the foot clinic, the orthotist will review this and either continue it or upgrade it to something more complex. And they're seen by the members of the team, so that a treatment plan can then be put in place, and this is kept under review by the podiatrist. Podiatrist may have prescribed medication also, and again that can be reviewed by the consultant, and then the consultant can have a look at the glucose and their sugar levels, etc. So the podiatry service have a referral management centre, which is a large call centre, and they will take in referrals there. They'll take electronic referrals and paper referrals. So we talk about a gold standard foot clinic. I don't know what gold standard is, but I do know that I've probably made this sound easy, that we've got all this set up, but it's taken a long time to get us to this point. It doesn't happen overnight. It does take a long time. And I look back 15 years ago, when I first started in the clinic in Glasgow, it was one of the first foot clinics, and all the others have kind of built up round about it. There's a lot of very committed professionals that work in these clinics. We all see the benefit of multidisciplinary working, and we value one another's skills. There's a lot of work into building the communication between the services. and I have to say, on preparing this presentation, it gave me the chance to kind of reflect on that. And I'm really proud to work in it. So I don't know about gold standard, however, I do think we deserve a gold star. So thank you for listening tonight. I'm open to any questions if you'd like to ask any.
Thank you, Gail. I think I've got my mic back. So we've got one question from Jamal. He said, I think GPs should play a great role in the prevention of ulcers. Do you agree? Yeah,
absolutely. They can help educate the patients to be aware of their feet first to start with, to look after their feet and to check them every night. And that is something that we try and educate patients to do, but obviously they're coming to us at the far end of their treatment, and if GPs can raise awareness with that and help patients not develop these wounds, then they wouldn't have to come to us.
Excellent, thank you. And another question from James Carter. He's asked, do you have a specific regular TCC clinic as well?
We have a clinic where we can do like a supramalleolar cast. We don't have a regular clinic to do a below knee total contact cast. We do have access in the north to our orthopaedic colleagues, and the service there, they can deal with that if we need somebody to go into TCC. But we use the Diabetic Walker boot, the rebound Walker boot, with a custom insole. We're able to manufacture custom insole very quickly, and we try to make the boots removable if we're possible, if we need a total contact type device.
Excellent. I think that's. I've got another question from Jamal. Do you use, is it vacast, vacast?
No, we haven't used
something you
that.
recognise?
I think I know the thing that you're referring to, but no, we've not used that. It's not something that we've looked at. Don't know why we would need it. I'm not sure where it's used and what kind of differences. I suppose that you're talking about using it instead of using a total contact cast. That's where we have used the use of the custom insole, which is probably quite unique to our service because we can use CAD/CAM to produce these insoles.
Excellent. And another question, they're all coming in thick and fast now. I think when the first person goes, everybody wants to ask a question. A question from Wilma Boyington. She's asked, how do you monitor patients, or how did you monitor patients through the current COVID crisis? Was it video consult, telephone? What did you do, Gail?
A mixture of both. We first of all telephoned all of our patients, first of all to cancel them all, March and April, all the ones that we had fittings, and then we were telephoning patients as they were sitting on our waiting list, and then trying to do any virtual appointments with them. And now we have set up an advanced clinical referral triage where we are trying to triage them as they come onto the waiting list, direct them to a virtual clinic which is called Near Me in Scotland, but we are finding we can do it with some, but we can't do it with all. And I have to say, some of the work that we can do on a Near Me, I can find we can just do the same amount on a telephone call. And for the patients who are perhaps not tech savvy or a bit concerned about using it, then they're happier and more comfortable with a telephone call. We have also gone to doing a lot of home visits. We've had to resort to a kind of home visit service at the minute, which we are now trying to revert back to outpatient services.
Excellent, thank you. Another question from Ger Matthews. It's slightly related to diabetes, but I think it's quite a good question. What off-the-shelf splint would you recommend for foot drop if the patient is diabetic? Would there be something you would recommend on that one?
No, there's nothing specific I could recommend for that, because everybody would be different and everybody's needs would be different. So I couldn't say that there was something that I'd go, oh yes, I'll use that. That's not something I would be able to say.
And there's a couple of questions relating to compliance, obviously, with regards to the difference between TCC and perhaps using an off-the-shelf device. How do you best cope with that in terms of compliance from a removable walker, from say, a TCC?
We actually have quite good compliance with patients. You obviously get the odd few that are not wearing it, or you can tell are not wearing it, but most we don't have an issue with that.
Good. And I think one last question from Joshua. He mentioned obviously the fact that you guys use the total contact insole. How do you fit that within the walker boot? Do you place it inside the liner, or do you put it outside the liner?
Place it inside the liner.
Okay. Nice and quick answer there.
Yeah.
Pretty much a 50-50. So I think that's pretty much all the questions, I would say. Thank you so much for your time. That was really, really interesting. At this point, I shall do a quick product demonstration just to go through the Rebound Diabetic Walker, its features, and also do a quick fitting onto myself. Normally we'd have someone fitting it, but with social distancing, etc., it's a little bit more difficult. So thank you again, Gail, and I'll go over to the table cam and we'll just run through the Diabetic Walker. So the Diabetic Walker has been around now for 5 or 6 years. It was derived from the Rebound Walker that we have from our fracture range. So very similar look, but there's a couple of key differences that make it a specific Diabetic Walker. You can see the ventilation holes around here have all been filled in to make sure that there's no foreign objects getting into to the boot. And we also have a small window at the back here, and that's really to make sure that the pumps or the bladders are inflated, but it also allows you to make sure that the foot and the heel is in the correct position. There's a more durable sole as opposed to the Rebound Walker, because these patients can be in it for a little bit longer. And we also have rubberized sections on all the areas where it could potentially cause any pressure areas. So there's a rubber section on the toe, rubber section on the top of the walker, on the anterior shell, but also on the back of the walker. And you can actually cut the walker down, which allows you to splay the walker open to incorporate a larger calf because it's sized on a shoe size. You also have the toe bumper as you would normally have, and the Diabetic Walkers are slightly larger in width to accommodate that patient type. You then have the 3 strap configuration, so you have one over the top of the foot, which we open up here. There's also the 45-degree ankle strap, which is important to make sure that the foot is positioned correctly and is at the back of the walker. And then you've got the top strap here, which actually incorporates the pump system. We've got a plus and also a minus here, and that's incorporated into the strap. Now, the main part of that is the fact that when you take the anterior shell off, you have the liner inside. Now, the liner doesn't actually have any working parts within it, and what that allows you to do is actually have a wash one, use one scenario. So there's no working parts in the liner. All the working parts are actually in the walker boot itself. And you can see that the bladder section here actually has a tube which goes into a blow-off valve at the back. And what this allows to do is for the patient to pump up to a certain level of 53 millimeters of mercury, and it means that they're not actually going above the designated inflation. There's some other systems where you have to maybe use a gauge through eyesight, etc. The patient can pump as much as they like, but they will never overinflate it. And the real reason for the inflation bladders is not for immobilization, but more for positioning. So that's why it's integrated into the walker and allows you to have a wash one, wear one liner. The walker does come with a DH insole. Correct me if I'm wrong, Gail, but I believe you may use that while you make your TC, your total contact insole. And that's just
that would be in there temporarily until we could make our own custom insole.
Excellent. But if you're not familiar with it, it's just a hexagonal system. So you can use that as the treatment, but Glasgow are going a stage further by making their own custom total contact inlays. And as I said, you just take the hexagonal pieces out to create the pressure leveling part across the ulcer. You then have, each walker comes with a Diabetic Walker fitting guide, so that the patient can go away with fitting instructions, with removal instructions, but also there's some good pictures so that they can don and doff the product correctly if they have to take it on. But obviously you want them to keep it on as much as they can. And there's also some care instructions, etc. at the back. And also if you're washing the liner, and all the care instructions at the back of the liner. You mentioned compliance there. So you may use other ways to do it, but it does come with compliance straps. You can see these blue sections here, and the idea is that you look it through this little section at the front to wrap the walker in, and then you'll know if they come back for their follow-up and it's been broken, you know that they may have been tampering with it. And you also have a pair of diabetic socks that come with it as well. So the main part of it is to make sure that we have the ability for them to inflate it, but not over-inflating it. As I said, it has the blow-off valve at the back. So that's the product itself. I'm just going to move over to the seat just to show you in terms of from a fitting point of view. So we've already got one in my size. The one I was showing you was a small, slightly easier. So yeah, it's on a foot size, and it's just a case of opening up the walker very simply for the patient. You take the anterior shell out, and you'd also have a pair of diabetic socks there. Now the first part is to do is to make sure that the liner is positioned into the shoe. Now, as Gail said, they make a total contact inlay and put inside of the soft good, and then you would strap up the calf section there. I won't put the hexagonal section in, but you would pop the walker into the foot and make sure that the foot is positioned right at the back of the walker. And you can use these little windows here to make sure that the foot is correctly positioned. You've then got the anterior shell, which may differ from some other manufacturers, but you make sure that the anterior shell sits flush with inside the posterior shell, rather than it being across the top of the posterior shell. So you make sure that that's sitting in there. The reason for that is to make it a little bit more like a cast. So you're minimizing the amount of space for the air to fill. So you've got less room for movement here. Good option here for the 45-degree ankle strap to make sure that you're pulling it nice and tight so that the foot wouldn't move about. And then you've got your final strap here, which allows you to pump it here. Now, as I said, you've got the plus section here and the minus section there. And to get going, it's always a good idea just to put a little bit of pressure behind that, just to give yourself a little bit of resistance. And we recommend between 15 and 20 pumps just to get it going, to get the air into the bladders. And once you get to that section there, obviously the diabetic patient might not feel it, but you can just double check. You can see that the bladder's inflated within the little windows, and you can just press that in to make sure that the foot is in the correct position. Now, obviously, we've got a bit of height discrepancy there, but we try to minimize that with height discrepancy, that the patient's comfortable. There is an even up available that you can put onto your other leg to even you up. But as you can see, the concentrating is really from the gait dynamic to make sure that the heel strike to the toe off is as natural as possible. So that's a diabetic walker. Nice and quick. So I'm going to walk casually over to the main part again with my diabetic walker on. Just come back to, I've come back to quite a lot of questions. So I'll just see if we've got a few for you, Gail, or whether or not there's any for us here at Össur. There's a question that's quite interesting for you, Gail. What particular condition would decide, is there a particular condition that you would decide a TCC against a diabetic walker?
Usually we would be referring for a TCC if they're of a very unusual shape and we wouldn't be able to fit it into a diabetic walker.
Okay. So the diabetic walker would be your first choice, but
it would be our first choice.
Compatible.
Yes. Yeah.
And do you find compliance an issue between the TCC and the walker? You mentioned earlier that's never really not an issue for you.
Not really. There's been a few people who've been in a diabetic walker and then they've gone to have a cast applied, and then it's one of those ones where the wound is just doesn't seem to ever heal, and it didn't heal in the walker boot, wouldn't heal in the cast. And the patient themselves found the cast more claustrophobic, so chose to come back out of the cast. So we have differing opinions. It depends on the patient and depends on what they can cope with, really. But we find that most people cope very, very well with the walker boot.
Excellent. And an interesting question from Gillian Toz. She said, "Hi, Gail. You said you work with orthopedic and vascular consultants. What are the benefits for diabetic patients working with those two consultants?"
Well, a lot of diabetic patients have come with vascular disease, so to have access to vascular services straight away, it means that they can give an input to the patient's treatment, and they can also have access to vascular surgery, which could help the healing of a wound if we have wounds that are perhaps not healing at all, and if they have access to vascular services, they can then do MRA and see if there is an actual blood supply, and if they can provide a better blood supply that will help heal that wound.
Quite an interesting question here. If you did have a bilateral case, would you consider using a diabetic walker on both sides?
Well, funny, we have had a few. Not many. I could probably count on one hand. I can still picture them. But yes, we have had people in bilateral bilateral walker boots. They've probably been a more younger demographic rather than an elderly, so their balance was pretty good to start with. And yeah, they've maybe been in it for a short period of time, but yes, we have done it.
Excellent. Good stuff. There's quite a lot of questions there at the end, but yeah, I just want to say a big thank you to Gail. Really interesting discussion. I had lots of people on there and lots of questions, so thank you for taking the time to answer them. And hopefully we shall see you in person soon. Any excuse for me to get up to Scotland, Gail. So
thank you for inviting me.
So thank you all for attending. I hope you enjoyed the evening. There was just one last thing I wanted to mention. That's been our 13th KOL webinar. We here at Össur have been working hard over the last 3.5 months, trying to give education through this difficult time. But as we move into the holiday period, a lot of the team here, the sales guys, the academy and the clinical guys, the marketing guys, are all taking a well-earned break. So it's more difficult to produce these types of things. So we're going to take a little bit of a break in August. We will be back in September. We've got some really interesting speakers lined up in September. So do look out for your invitations coming in early September. A big thank you to Gail again. But we're going to go and have a well-earned rest and back in September, hopefully. But stay safe. Thank you for attending, and hopefully we'll see you soon. Thank you.